Okay, let's see how this is looking and sounding. Let's see. That looks good. So let's go find it on YouTube and make sure all is well, because I think all is well. Okay, I think it's looking good. Very good. Okay, so just want to make sure all is well here. And then we'll share it and we'll be off to the races, wherever the races are going. Okay, just a sec. So very sorry. Here we go. Almost there. Almost there. Getting going. Copy link. There we go. Here we go. I'm going to post it on Twitter. And after we do that, we'll be good to go. I think all will be well. Perfect. I think we did it. We did it. All right, everyone. Happy Saturday. I am Dr. Patrick Lockwood. And for the sake of clarity, this is just Patrick, but this is UnShrink Me, a weekly podcast dedicated to you, the consumers of mental health services. So if you're brand new, UnShrink Me is a podcast hosted on my YouTube channel, The Psychology Checkup. And the goal of my channel generally, and this podcast specifically, is to provide people who are consuming the different types of mental health services, whether it's therapy or coaching or counseling or whatever it is, the best possible feedback and criticism of ideas that are trendy, important, and concerning relating to the concepts of mental health. So that is the whole spirit of this podcast. It's for the consumers of services. And though I am lucky because I am joined by people like Angie, who is here in the chat, thank you so much, who come from the field, from the counterpoint side of things. I happen to be in the profession technically still, and so I am part of the people I'm here to critique. And so I'm always happy to have people either from the profession or counter to the profession in some ways, supplementary to the profession, to add to the discussion. I have a lot of great people that come to the chat, and I'm very grateful for that. So thank you for being here, Angie. So this is our weekly podcast of UnShrink Me. This is episode 76. We are in the new jacket again, which should be fun, I hope. And today we have some, I think, kind of complicated topics that I think are very important for people to understand. And some of them are themes from last week, and some of them continue older discussions as well with recent conversations from Twitter. So if you are new to this, just know that I go to Twitter every Saturday and go to posts, comments, questions, critiques that have been tossed in my direction, either conventionally and consensually or not, and try to figure out what to do with them. And so you can follow me on Twitter at Alobha Patrick, at ALOBHAPATRICK. That is my handle on Twitter, and I will be live tweeting everything that we talk about here today. And as always, before we get going, this podcast is not NOT, not sponsored by Celsius. However, I love this stuff, and I think it adds to the discussion in so many ways. So today's podcast, we have a couple of, I think, important topics that are worth really considering in a somewhat more deep way, which is exactly why I wanted to talk about them on today's podcast with everyone who comes to the chat, especially. So we're going to talk about the challenges of managing harm in psychiatry, and I'll add clinical psychology. That's one topic. And then I also want to talk about the concept of being in remission, because I believe when it comes to the harms of psychiatry and psychology, over-treating people is one of the leading causes of harm in our profession. So I want to make sure we don't ever over-treat people. And what does that mean to be over-treated? And what does in remission actually mean? And I also want to talk just a little bit about the concept of borderline personality disorder, because this is yet again one of those very complicated and scandalous topics online in particular, but I think even in the profession more generally. So I want to talk about all three of those things today, and if more fun stuff comes up, if more shows up in the chat, I'll be eternally grateful, because I like chatting with people and having people come add to the discussion. So again, without further delay, we're going to talk about BPD. We're going to talk about the concept of being in remission, and we are going to talk about what do we do about the harms of the profession. And so in order to get this kicked off correctly, I'd like to start off with, I believe, someone who I've interacted with a few times. I don't know this person well, so I'm going to retweet them and we can talk about what they're saying, which will lead us into the conversation about harms. Okay. So this person is, I guess their name is William, but their handle is at VAUNTEDREVELRIE. So I believe that's at Vaunted Revelry. I don't know what that means, but who knows. So let me start with this person's post from June 28th, so about 3 weeks ago. And I think it will nicely lead us in and kind of introduce us to the topic of harm with mental health professionals. So give me just a sec. Okay. Here we go. So William said on June 28th this year, he said, thinking about how sadistic mental health professionals can be. How many of them are actually not looking to help clients overcome their struggles simply because they don't like the client? How many of them actively work to harm the client? And William ended the thought with, it's a disturbingly high number. Now, I have no clue. Hey, Seth, glad you're here. I have no clue where William got this idea that a disturbingly high number of people either harm patients because they don't like them or just generally are actively trying to harm someone for various other reasons. I don't know. I'm not sure where that comes from. I assume it's possible. I don't believe it's likely. I believe that as many critiques as I've stated about the profession here on this podcast for 76 episodes now, I believe I've been very clear that I think that there's so much good that can come from the profession if it's done correctly, if people are trained correctly, if they manage countertransference correctly, if they understand the pros and cons of their approaches, if they do informed consent correctly, which we'll come back to. So I think there's so many things we can do to help people if it's done correctly. But then that leads us to the question of, well, how many people are intentionally harming their patients and their clients? I would say that that's probably a small number. Career Flex is here. Our buddy Jake is here. Gang, gang, he says. Should we be tossing up some gang signs? I couldn't get whiter. Wearing a Joseph A. Bank jacket, an overpriced white shirt, and drinking a Celsius. I don't think I could possibly, doing a podcast on a Saturday, I couldn't possibly get whiter. The whitest thing I do all week is this, and I don't know what to do about it. So gang, gang, indeed. So back to the original topic. I think, how sadistic are mental health providers? I think some are. I think there is a subset of people in the profession, psychiatrists, psychologists, counselors, therapists, who have a sadistic streak that they don't have a good relationship with. Some of them might be more temperamentally sadistic. And they might end up in certain types of more sadistic types of therapy. So for instance, ERP and behavior therapy, I think, lend towards the sadistic type of person. So maybe those types end up there and they do cause harm to people and maybe they get something out of it. I don't know. I couldn't tell you. There's no good data on this. I wish the profession did a much better job of using personality testing to understand the types of people that end up in the types of specialties and things like that. That would be great. Jake was clarifying what gang gang means. That's my squad. Yes, I'm aware. Thank you so much. And so glad you're here as always. And again, I don't know how many people are actually sadistic in the profession. I think that these are all traits that are a spectrum. So you think of it like percentiles, basically. So people that are at the first percentile of trait sadism would not be super interested in causing harm to people. They wouldn't get much psychological satisfaction, joy, euphoria out of hurting people or causing distress in other people. Whereas someone at the 99th percentile absolutely loves it and lives for it. I would imagine most people in the profession are at the 50th or below in terms of trait sadism, but I could be wrong. I imagine they're below average, though I imagine there are subspecialties and subtypes of people that come into psychiatry, psychology, etc., who are interested in harming people. And I have no clue how frequent that is. I wish I knew. But it sets us up nicely for the conversation about what does it mean to harm people less, and how do we handle harm in the profession. There's some chats here, so I want to get to them. Seth says, I can't imagine people becoming therapists just to damage. Emphasis on just, I imagine. I can imagine hidden agendas to bring about certain social change. Absolutely. I think a lot of people in the profession have a variety of hidden agendas. So that's worth considering. Career Flex says, I think actual sadists is pretty small, right? But I think some unwittingly do harm and they're not aware of it at first. And there's too much to look in the eye, as in, do your clients get better? Yeah, I think you're both right. I think you're both correct. And I just don't know what we can do about it other than try to have these conversations, because until we do more screening, I don't think things are going to get much better in the profession anytime soon. We don't do much personality testing. In the field that created personality testing, we don't use it in our own profession. If I could, I would try to include personality testing in graduate admissions, if it's possible, which I believe is a signal that maybe we should talk about what do we do to reduce harm in the profession. So 4 days ago, I was chatting it up with my buddy Nick Tabor on ye old Twitter, and this person named Alpaca joined the conversation and asked me a question. And I said, I don't have the time to write out a response, but I'll talk about it on the podcast. And so here we are talking about it on the podcast. But before I get to that question, someone new showed up. Hello, Patrick, Mr. City 7. Glad to join the podcast. I think therapy is delicate work, and the training pipeline does not train for recognizing such nuance. Agree, Mr. City 7, I agree. Though your thoughts are welcome on this next topic as well. So, again, I was talking on Twitter to Nick Tabor, and this person named Alpaca joined the fray about 4 days ago, and they asked a really good question, which I didn't have time to write a response to, so let's talk about it here on the podcast so we can have a full discussion with everyone here in the chat. Thank you for being here. So let me retweet it real quick. Okay, here we go. All right, so Alpaca, and their handle on Twitter is at Alpaca Kudde. Alpaca Cood? I don't know. Couldn't tell you. But I'm glad they asked the question. So they're talking about something that's problematic, and then they asked the question, how do you think psychiatrists should deal with the problem of harm? As a patient, I can tell you the impact is huge. Sometimes I think about solutions. How do you think you can deal with the situation with a not workable situation for therapists? So for everyone who is not going to take the time to go read, let me tell you that literally speaking, there was a giant thread that I was responding to about the fact that professionals, this is a little inside baseball, and so if this is too far inside baseball, please obviously let me know, because I would love to know if this is boring. So a lot of people think that therapists and psychologists and psychiatrists have no systems of accountability, and that's just not true. We are bludgeoned to death by malpractice insurance and the risks that come with losing your insurance. We are bludgeoned to death with licensure fees and trainings and things like that. There are so many things that we are forced to do in the profession of clinical psychology and psychiatry to stay current. And so our real problem, in my opinion at least, is we have all sorts of systems of accountability. People can randomly complain about us to our licensure boards. And I'm not saying this to be whiny or whatever. I'm just telling everyone that, of all the professions, because things are so subjective and nuanced in the clinical world, anyone can complain for any set of reasons, whether they're valid or not. I say all sorts of crazy stuff on Twitter. I can get, shunned, written up, whatever, suspended for the things that I say, even if they're perfectly, normal in many ways. So the conversation backdrop before this question was, what do we do when there's a game theory that makes it look like we have to protect ourselves and we have to be on the defense in the profession? And so the question is, what do we do with the harms of the profession? And fair enough. So the thing that I think about all the time is, what exactly are the harms, and then what are the causes of the harms? Because until we address the causes of the harms, there's quite literally no way, I think, to actually address the harms, right? So what are the ways in which psychiatrists and clinical psychologists harm people? So I would broadly group it into various categories. Category 1 is over-treatment. Phil, no, you're not late. You're here right on time. Thank you so much, Phil, for being here. So I think there's over-treatment is one way that people are harmed by the profession. I think there's under-treatment, and I think there's inaccurate treatment. So neglect, over-treatment, and inaccurate treatment. And so the people that are neglected by the profession, the people that don't get the help that they need, right? So some people are on meds when they shouldn't be on meds, and so they get the wrong treatment. Some people get meds that they don't need, but they need other meds. So fixing the problem of differential diagnosis, training people to be much better at differential diagnosis and figuring out what the patient's actually dealing with, or if it's no diagnosis, which is often the case. That is extremely important. That's one way we deal with the harms from the institutional level. We have to have much better training. We have to have much better training by people who actively do the work successfully, in my opinion. Right. And Angie just said something in the chat that I want to get to. I won't forget it. But I just want to finish this point before I get to it, which is if we're going to deal with the harms of the profession, we have to start at the level of the institution first. And as a professor in graduate psychology, I care about this because it's not only a piece of my living, but like I do care about my reputation, believe it or not, despite the absurd things that I say. Like I have very good student reviews, and I am not exactly a middle of the road professor. I'm kind of an out there kind of guy in the university. And so I actually care about the quality of what my psychologist students become. I want them to be great psychologists and not be hurting people and be thoughtful. So I say we have to fix a variety of things in the institutions. That's one way we deal with harm. A second way that we deal with harm is we create more systems of accountability for when people are actually harmed. And so right now, licensure complaints is one version of accountability. Civil suits is another version of accountability. But what's missing, I think, is a sort of professional accountability from your peers. I think one of the worst problems in clinical psychology and psychiatry in particular is that most people who do these services for a living, who are these professionals, are not good at keeping each other accountable. One of the worst parts of my profession is how there are many people who are rather sick and immature, or both, and they don't have an actual conversation with people they disagree with or dislike. And as a clinical supervisor of interns, I encourage my interns to speak up to me and tell me what they don't like, what doesn't feel correct, what is too much, right? And so I really believe firmly in like the most clear and unashamed way that if I am your colleague, you should be able to say any criticism of any of my clinical choices that you want. I never am above reproach. There's nothing so brilliant about me or perfect about me or special about me that my clinical choices are above reproach. So what I need is I don't need a strike against my license because I tweeted something stupid. What I need as a professional, in my opinion, is I need my colleague to look at me and go, what the hell are you saying? Or if I'm in a program as a consultant, etc., and I'm not showing up right, or something is wrong with me, or I'm not doing my job correctly, or I'm slacking, I need my colleagues to be like, what are you doing? So collegial accountability is the number one thing that is missing, in my opinion, and licensure boards do not solve that problem. Professional associations like the American Psychological Association and the American Psychiatric Association do not solve that problem. Those are worthless organizations that have only started to make the science and the treatment of people worse, although they have funding mechanisms and social like status and clout. They really aren't helping the profession anymore. They have become useless political shills. So really what is missing the most, the thing that I care about the most as a clinical supervisor, as a professor in the Graduate School of Psychology for my university, is I care about personal accountability with my colleagues, because that is where we can make the most change the most quickly. And that is where we can help everyone get better the quickest. And that is what our ethics code, the APA's terrible ethics code, says, is that the first remedy is to try and directly deal with the problem with the person before you go above their head to their supervisor or to the board or whatever. So we have to fix the training model. We have to fix the institutions, especially psychiatry. Psychiatry is some of the worst training on the planet. It's just not very, it's just, the medical model of training is not great, right? But we have to fix that, but we also have to fix collegial accountability. I need my colleagues to come to me. I don't need my colleagues to go talk to the board or talk to my boss. I need them to talk to me, right? And thankfully, I haven't needed this very much in my career because for the most part, my insanity is useful. My personality differences and the ways that I show up are actually useful. They actually don't hurt people, thank God. Now, I have the capacity to hurt people, but I do everything in my power to take care of myself, eat as good as I can, a little extra caffeine. But other than that, I do what I can to stay relatively in shape, mentally, physically, so on and so forth. And so, generally speaking, I think it's extremely important that personal collegial accountability is a big part of how we fix harm. So there's preventative measures we can do to fix the harm problem in psychiatry and psychology, in clinical psychology. So preventative measures. But then from like a secondary level of care, we need perspective. We need to do something to, I think, in my opinion, help the people who have been harmed have bigger voices so that we can find collective solutions. I think the Maha types are trying. I think people like Angie here in the chat are trying. So I think there's things we can do to help accentuate the voices of people that have been harmed, like Nick Tabor and Angie and all these people. I think there's also more we can do to help them create parallel institutions that have better principles and better collegial dynamics that help prevent harm as well. And then whatever we can do medically to help people who have been harmed by meds as well. So let me go back up in the chat because a lot of people have been chatting. And by the way, grateful to all of you being here and saying everything that you're saying. Career Flex says, I don't know why we don't have like a version of the MMPI or something at those type of... Exactly. We should have some kind of testing because he said even in the Marine, you were assessed for psychopathy, etc. Right. Angie said, and this is very important. Angie said in the chat, I've seen many a patient report harm and be answered with, well, that's the standard of care. And she said, unfortunately, medication harm is not taught or recognized. So harm doesn't exist for psychiatry. So Angie, I have news for you, right? So here at my university here in Southern California, I have been given the privilege of teaching psychopharmacology to my graduate students. I teach to, 30 or 40 people a year, the psychopharmacology class. And I get the luxury of talking to them about medication harms. And so just know, Angie, I'm doing my tiny little part to talk about the existing literature on harm with my students so that they are well informed of what to look out for when their patients say they are prescribed something. And I always teach my graduate students that it is not our job to tell people what to do. It is not our job to tell doctors what to do. We are supposed to live in our scope of practice. And also, if we see that our patient is having some kind of potential side effect, and I say potential because we're not doctors and we don't know. We're not that kind of doctor. So we can just have a conversation and be curious with people about what they're experiencing because curiosity allows people to feel open. And so my students are taught to ask questions and be curious and support people if they do want to talk to their doctor or their nurse. And if it's a life-threatening symptom, straight to the ER, please. So Angie, you're not alone, and we can change graduate education. We can change graduate psychology. And I'm not the only person out there with common sense enough to have these conversations. Now, psychiatrists, roughly speaking, don't get as much of people like me in their ear. But if I could, I would certainly go teach at a psychiatry program if I could. Career Flex said, I had a client with schizophrenia in the past whose former therapist hooked her up with an ayahuasca ceremony, and I had a problem. That's absurd. Folks, I'm not a physician or anything, so feel free to not sue me, but feel free to cancel me. I don't think mixing ayahuasca and psychosis is a great idea. Mixing psychedelics and hallucinogens with psychosis seems like a really bad idea. But again, not a physician, so don't sue me or anything. Corey Grad is here. Thanks, Corey, for showing up. That's a difficult ask, since I've noticed many colleagues are conflict averse, unfortunately, which only reinforces the problem. Exactly, Corey. You nailed it. You nailed it, Corey. One of the biggest problems in the profession, psychiatrists, psychologists, LPCCs, LCSWs, LMFTs. It doesn't matter what the fancy degree or title is. There's this huge aversion in the profession to holding each other accountable as friends and colleagues. Cancel culture is fine. I can complain about you to your boss. I can complain about you to your licensing board and feel justified and good about myself because I'm going to save other people from harming you. But most people in our profession are cowards of the sort where they wouldn't actually have a conversation with you about their concerns. And that is crippling the profession hour by hour, week by week. Because the awesome thing about this profession, in my opinion, is the fact that we have the luxury of being different and having different approaches and different ideas. And with all the various differences of personality and backgrounds that comes into clinical psychology and psychiatry, we can shape each other and sharpen each other. But if we're too cowardly to actually have a conversation, then nobody ever gets to look at themselves differently. And like I said earlier, I am not above reproach. There's nothing I'm saying in this podcast that is above scrutiny. Scrutinize me, come at me, tell me I'm an evil, bad person, fine. Patrick Lockwood, Dr. Lockwood is unhinged. Absolutely. I just need more caffeine, right? Like there's just nothing. If you're a common sense person, if you care about what you do for a living, especially as a clinical psychologist or a psychiatrist, the most important thing is feedback from your colleagues and from your patients. And the problem that I see, if I could fix clinical psychology quickly, it would be to outlaw private practice. Because if you can go hide in a private practice, and this is probably the wildest take. This is my anti-capitalist. This is the craziest anti-capitalist thing I think as Patrick, an individual. I think private practice is where a lot of people hide. And I think it's totally easy to hide in private practice. And the reason I think it's easy to hide is because I think a lot of people want to be left alone and they don't ever want to be scrutinized. And I think a lot of people in the profession also like the privilege and comfort of being kind of like siloed and kind of like a guru. Maybe not all, but some. And so what I would say is if you really want to institutionally fix this, you fix all the things in grad school and psychiatry I was talking about. You fix the admission standards, do some personality testing. But also what you can do is you can fix accountability for peers. And one of the ways to fix accountability for peers is to not hide in private practice. And again, I'm not saying specifically that private practice is inherently evil or something. What I'm saying is if you are allowed to hide by yourself and not deal with other professionals on a regular basis, there's no guarantee for accountability. But if you're in a group practice, for instance, right, where it's an office full of therapists who have some accountability to each other and we have to interact with each other and maybe tag team a case, right? So I'm a family therapist by training and by trade. And so if I'm the family therapist and you're the individual therapist, we have to talk to each other to actually help the patient. Interdisciplinary teamwork. And it's very important that we never function in silos. And one of the biggest problems to me is that private practice therapists and psychiatrists hide. And because they get to hide, they get to get away with whatever and never deal with their countertransference or be accountable to people in the same way as working in a rehab where you have a good supervisor or clinical director, where you actually have to talk about these things. So that's just me. So that's how I would fix this. I would spend a lot of time. If I could fix the harms, if I could do preventative work to fix the harms, and I could do management work to manage the harms of people, because I'm not a physician, so I can't specifically talk about specific harms from meds. But, thinking systemically, there are some things we can all do to fix the harms of the profession of mental health, psychiatry, psychology, so on and so forth. First and foremost, change the admission criteria, which is going to mean changing the financial incentives of these programs. Number 2, personality testing to screen and either kick people out or give them remediation plans early on. Number 3, we need better training about countertransference and managing yourself, because the vast majority of people don't know how to manage themselves in this profession. They're not evil people. They're not stupid people. They're just regular people who quote unquote want to help, and there's a reason they want to help. And that's what they need to get a hold of. Career Flex says, it's hard to be collegiate I think you mean collegial, in a deeply victimhood worshiping industry. Which is why you have to have solid bros and brohenas. My supervisor is sublime. Good. I'm glad you have a good supervisor. Good friends, good supervisors are worth their weight in gold. I love being a colleague and I love being a supervisor, because I have to grow and I have to think twice and I have to be accountable, as do the people I'm working with. A lot of other chat comments, a lot of support. Thank you for being here to support the show, by the way. Angie says, I've been trying to help for years. They call us anti-psychiatry and dismiss everything. Do I dismiss you, Angie? Tell me. Until psychology and psychiatry looks at their own cognitive business, this will never change. Yeah, the cognitive dissonance. Yeah, there's a lot of cognitive dissonance in the profession, and the vast majority of people are very interested in hiding from their cognitive dissonance. They do not want to deal with it at all. They don't want to deal with their own countertransference. They don't want to deal with their hypocrisy, their desire to harm, their sadism, their masochism, their narcissism. They don't want to deal with it. Some of us talk about it actively. They block you. They can blind. Angie says, I'm hiding in coaching declined license. Yeah, I mean, listen, that's a choice. And I appreciate that you made that choice. You're trying not to overpromise or overdeliver, right? My niche doesn't fit in the traditional system, she says. Of course. Seth says, am I allowed to enjoy doing therapy at least? Now, Seth, do you want an answer to that question? Because I have all sorts of follow-ups for you. But the short story is, yes, of course you're allowed to enjoy therapy. And I got, again, some hell this week for always talking about the problem and how sick therapists are, but that's not what I do on a regular basis, not even on this podcast. You know, I talk about fixing systemic problems more than I talk about individuals being sick. And so, Seth, yes, of course you can enjoy doing your clinical work. What I would say specifically is that you should be very aware of the various types of enjoyment you get from the different types of patients you see, and why do you enjoy the things that you do? What is it about you that makes you enjoy those things? So is it some narcissism? Is it some sadism, some masochism? Is it because, this is what happened to you as a kid? You're trying to right the wrongs of the past? All these kinds of things. Some of it's normal. Some of it's not so normal. And I want people to understand the difference between the more ordinary stuff and the less ordinary stuff. And I don't think that makes me a radical person. Or maybe it does. I don't know. I would argue that the more you enjoy it, the more concerned I am about you. I think in the Buddhist sense, there's some balance in the world. And so if a large chunk of what you do is enjoyable as a clinician, I'm a little worried. I'm a little concerned because I think you might be getting more out of it than the patient, and I'm not so sure about that ethically. Career Flex says, I have firsthand seen group practices go absolutely insane. Of course they can. And Angie says, many of us do group supervision. Good. Do group supervision. Strong recommend. Even if you're licensed, have people you consult with. One of my favorite things I get to do is consult with people on a regular basis to stay sane, to stay accountable. I have created a life where I will always be accountable. Nothing I do is in isolation, thankfully. I always have colleagues looking over my shoulder. Anti-private practice. Career Flex says, is your most cancelable opinion so far. Therapists don't know how to run business is terrible. Take this week. So here's what I will say. It's true that a lot of people can't run a group practice, for sure. However, what I will say is that most people can find one quasi-business savvy person to create a small community with. Because if you think of it like creating a small community of people to work with as opposed to a business, then people are more motivated to play fair. And you can hire a CPA or a consultant like me to set it up for you. It's like not rocket science in your given state or city to figure out the laws, what taxes you have to pay. Is it better if it's an S Corp? Who are the owners? Like all that crap is not rocket science. A good accountant can do 90% of that for you. And so what I would say very, very genuinely is it's very important to never hide. And so many therapists and psychiatrists and psychologists are just little gurus. They have a little private practice where they're special and they help people in their special way, and that's it. And like I get that therapy is a special relationship, but I'm very clear that we need accountability as people. And I don't think it's just me projecting because maybe I'm out of control and insane and I need more accountability than the average person. I just don't know anyone who stays sane without accountability in their professional life. I just don't. I can't think of a person I met. My favorite person in the world in this profession who I went to grad school with is a psychologist out here. He was my best friend forever, and we kind of grew apart, but we're still friends. And it's like he has accountability in his life. And I'm a piece of that, but I'm not the only piece of that, you know? And he doesn't hide in private practice. He's an excellent psychologist, but he has people he's accountable to. He's got a spouse who's in the profession. He's like a great guy. And so as someone who I admire in private practice land, one of the like little subdivisions of therapy land, the world's worst theme park, it's like a tough place to live, but he's figured it out. Everyone I know who I respect has not just lived on an island where they can do whatever they want in privacy and in secrecy. That is where harm happens, in privacy and in secrecy. So privacy is necessary to have a working therapeutic relationship. But privacy is where people can hide and get away with things too. And therapists are regular people for the most part. And so regular people have flaws and problems that make it harder to do their job ethically on an ongoing basis, which is why accountability is great. And person-to-person, peer-to-peer, friend-to-friend, colleague-to-colleague accountability is the best. Corey says, Corey Grad, thank you again for being here. As someone transitioning into private practice, I'm actually on board with the outlawing of private practice. Yeah, exactly. And I'm sure you have some similar experiences. Career Flex says, that sounds pretty negative, Patrick. Not everything is pathological. I didn't say everything is pathological. This is not an all or nothing statement. Yeah, getting into a group practice where you don't have to worry about some of the BS of the business is great, right? Because you can just focus on practicing and enhancing your skills. And if you have the right colleagues, it really helps too. So the overall question that Alpaca posted, which I talked about maybe 20, 30 minutes ago, was what in the world can we do to deal with the harms of psychiatry? And I added clinical psychology. And so I'm proposing two categories of solutions. I think there are preventative solutions to help with the harms of psychiatry and clinical psychology, which include better training, better clinical supervision, more clinical supervision. It also requires better education around adverse effects of medications, more honest discussions about harm, which I bring to graduate education. Also, another thing that I like to add to the mix is more honest discussion about what the limits of our competence really are, because some people really believe they can do a lot more than they're actually capable of. Like, we can't change people's lives. That's not what we are created to do. We're part of their journey, but the change agent is the patient, not us, right? And then, so there are preventative solutions, and I can outline dozens of things, like including personality testing in graduate school admissions, which we should be able to do because we created them. Like, we should be able to use them to help us do our job better. Career Flex says, we are going to be Terry Real Maxing. I certainly hope we are not going to be Terry Real Maxing. Jonathan Cogburn, very glad you're here, Jonathan. Good to see you, sir. I hope you're getting some good squats or sprints in, because he's usually working out during this podcast. Jonathan says, I was honestly kind of shocked at how lonely private practice was when I was there. Exactly. Nothing like the collaborative group creativity I had in grad school. It can be great, but only with a lot of effort to hold peer supervision or similar. I agree. Yeah, I mean, I think, again, and I'm not saying that you should be social for the sake of being social, but peer-to-peer accountability is far more powerful than people think. And it can prevent us, from needing to go get, a licensure violation of some kind. So we can prevent harm and we can manage harm and decrease the frequency of harm through better peer accountability. I don't think that we need more licensure criteria, whatever. I don't think more restrictions is going to make it better. I don't think there's a lot we can do to actively manage harm that we're not already doing. I think the system does its job the best that it can. But I think culturally what is wrong in clinical psychiatry and clinical psychology is peers don't actually give a crap about each other enough, or they're afraid, they're cowards of actually having real conversations with people. And some of the people here in the chat, I have had very crystal clear conversations with in our DMs about my behavior online. I've asked them, is this too far? Am I missing something? What am I missing? And you know why? Because they're probably going to tell me the truth. They're probably not going to sugarcoat things about my behavior and how absurd my behavior is. And without bro accountability, as some people would say, I probably would suck. I would probably suck real bad. I would probably be very unethical and unhinged in every way, shape, and form. And as fun as it is to be kind of quasi-unhinged, high on caffeine and stuff for a podcast, I don't want that in my day-to-day life. It doesn't feel good, and it's not good for people. So I think it's really important that we create a culture of actual accountability as friends and colleagues could and should do for each other. And I'm blessed to have family and friends in the profession that have helped me stay accountable to the extent that you can rein somebody like me in, So I think accountability is extremely important. I think again, I'm not much of a drinking person, but beers with colleagues. If you're a drinker, if you're the kind that does drink, beers with colleagues, talking about the profession, talking about life, talking about everything, can help you unearth some of the, challenges and walk you through your problems. I've got a couple of professor colleagues I've hung out with, and we go out, we have a beer, we talk about what's going well, what's not going well, how to be better professors, how to, help people as mentors, and it's great. And it's one of my favorite things I get to do. It's a privilege to do, and it keeps me accountable, and it keeps the other people accountable. So a culture of accountability culture is missing in the profession. Cancel culture, sure. The anti-psychiatry people can cancel the psychiatry people. The MFTs can cancel the psychologists for being snooty and full of themselves, and so on and so forth. The conservatives can cancel the liberals, and the liberals can cancel the blah, 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 and it just makes me want to just run off a cliff, basically, because who cares about all of that? That's not accountability. Accountability is colleague-to-colleague conversations that are encouraging, that are critical, that are clear. Encouraging, critical, and clear, that are mutual, that are not attacking each other. Attacking each other is such BS in so many ways. And I have the luxury of people. I think I've done my best to cultivate a group of people that are clear, critical, and encouraging, but not necessarily attacking. And that is where we actually get to grow as people, because we all need people in our life that are encouraging. One of the biggest things that's lacking in grad school is encouragement. It's all this drudgery and compliance and professionalism and all that stuff, which is not encouraging. Now, I am grateful for my colleagues at my university because most of them are actually very encouraging. They're positive people who are not miserable idiots. And so I have great colleagues. So I'm very blessed and privileged for the people that I get to hang out with and work with. The problem is many institutions are just factories, or they're traditional academic institutions where people are just miserable and stupid. So encouragement, criticism, clarity, missing from accountability in our culture. We fix that, then a lot less harm happens, in my opinion. So that's topic number 2. Okay, so I think I beat that to death. I have DM'd you, Career Flex. Don't lie. Don't be a liar. Fucking liar. Which leads us to my second post, which is the in remission question. What does it mean to be in remission? So let me discuss this right now. Okay. So Chris Palmer, an MD. I don't need to DM you. Career Flex says, you've never DM'd me about your behavior. Oh, please. So I'll DM you later. So Chris Palmer, who is I think a quasi-famous or very famous psychiatrist, posted this early July 2nd. He said, according to the DSM-5-TR, our diagnostic Bible, which of the following diagnoses can you never be undiagnosed with? And so most people said bipolar. Second was alcohol, then PTSD or OCD. And so it was kind of like a trick question, but basically the thing I retweeted was, what does in remission mean? And so do you want to prevent harm from people? I think one of the things that the APA, the American Psychiatric Association, could do better is be extremely clear about what it means to be in remission. So for insomnia, for instance, in remission means fewer than 3 times a week for 3 months, or for a month, you're not having insomnia. Oh, did I lose you? I think the stream died. Or is it back? Oh, I think we lost the stream. Are we back? Are we back now? I hope we're back. Did you lose me, guys? I just got a notification that the studio went offline. This is one of the challenges of live streaming. I'm in YouTube studio. It looks like it's still live, so please let me know if I'm missing anything. Okay, seems fine to you? Cool. Thanks, Corey. So, yeah. So, not about your behavior. Yeah, I'll get you about my behavior. No problem. So let's be clear that in remission is one of those things that we could fix tomorrow. If we did in remission from PTSD like we do with substance use disorders and things like that, we could harm people a lot less. Thanks, Seth. Thanks for everyone who's checking in with me. Sorry about the error here. So most disorders in the DSM could be more clearly defined in terms of their remission criteria. So some have very vague remission symptoms and some are specific. So insomnia, very specific. Other disorders, very vague. And so you want to prevent harm, you want to decrease harm. We could make the remission criteria more clear, more precise, and then we could have recommendations for what to do with people from a relapse prevention perspective or a maintaining wellness perspective about what to do when they're in remission. Right? And we could decrease the treatments. We could taper off the meds, so on and so forth, to help people. And so you want to hurt less people, you need to have better remission criteria because for the most part, many of these chronic illnesses like schizophrenia, bipolar, major depressive disorder, even PTSD, they don't magically go away just with good therapy or good meds or both. Usually, you have to have an ongoing relationship with these problems to manage them. So what we'd have to do is change the remission criteria. That's another thing we could do. If we change remission to crystal clear defined expectations like insomnia. Insomnia disorder means you have 3 or more nights a week of difficulty with sleeping, not being able to fall asleep, not being able to stay asleep, disruptions, waking up too early. So 3 or more nights a week for at least 3 months. Crystal clear definition of a disorder. Great medical issue. So what if we treated every diagnosis like that, and many diagnoses are not? Number 2, what if we made remission criteria equally as crystal clear as the actual diagnosis? So when you're free from these symptoms, or you're less impaired by these symptoms, then what's the follow-up? Because the recommended follow-up can be ongoing therapy, can be ongoing meds, lifestyle change you should keep doing, things like that. When I discharge someone, I tell them what they talked about with me. We summarize, and we talk about what do they still want to keep doing after they're done with me. Because it's not like the problem goes away and you're done doing anything differently. When you come to psychiatry and psychology, you're going to have to keep doing things differently when you're done. So staying different is part of the plan for everyone. So change and focus on remission would be great, and making remission criteria extremely specific, which they're not, and what to do when you're in remission, which is not discussed. So the final topic for today's podcast, brought to you by Career Flex, Jade the BPD coach, and Ryan Rogers, our buddy, was a quasi-controversial post. And so Ryan Rogers, who has a very popular podcast on YouTube, which I really encourage you to check out, because I believe that Ryan is trying to get a lot of voices together. And I think that's pretty cool. A lot of people in the profession don't do that. So Ryan McRogers has the Reality Therapy podcast on YouTube. Check him out. This week he released an episode with Career Flex, who's here in the chat, Jade the BPD coach, and others about what to do with borderline personality disorder. And so the two of them have been getting dragged, Jake and Jade. And so I just want to discuss my contribution to the discourse on how misogynistic and all this stuff they are, and what exactly is important about the condition that is worth considering that the average clinician and the average professional does not, and the average patient does not. Okay, so I'm not going to recap the entire podcast because that's absurd. Go watch their podcast on YouTube on the Reality Therapy podcast with Ryan McRogers. So go there, But here's what I said in summary. So I said, and I quote like 4 days ago, BPD, borderline personality disorder, is a complicated condition. Because it's a condition. It's not the whole person. And I said, number 1, managing when a person is engaged in splitting, idealizing and devaluing, and projective identification can be a challenge. And I'll explain more about that. Number 2, more importantly, clinicians have to manage their countertransference. Managing number 1, which is splitting, defenses, projection, etc., effectively requires above average self-awareness and discipline, and most therapists don't have either. So let's be clear that working with any personality disorder is a bit of a challenge, because personality disorder symptoms are what we call ego-syntonic. They are natural to the person. They feel correct to how they operate in the world. They don't feel foreign. And so people struggling with BPD, who are, let's say, not in recovery or struggling in their recovery from BPD, are really struggling with defense mechanisms like devaluation, idealizing, splitting, projective identification. They cannot tolerate their internal world, and so they rely on these defense mechanisms. And recognizing them isn't super difficult, but recognizing the game you're stuck in because of those defense mechanisms is more difficult. Which leads us to part 2 of what I said, which is therapists are just regular people, like I said. And because we are regular people, we have our own baggage, which makes it harder for us to recognize the games that we get stuck in when we're dealing with people who happen to have personality disorders. including and especially BPD, and I would also say narcissistic personality disorder. So if we could be super clear about the game that we're caught in, if we're caught in a projective identification game with the patient, if there's a dynamic between us that we can identify and talk about and have better agency over and collaboration about, the patient's more likely to get better and get into recovery easier and stay there. It's really simple, but it's complicated in the sense that the dynamic might be obvious. The game might be less obvious. And what do we want to do to unwind the game? So we have to pay attention to the professional, we have to pay attention to our countertransference. Sorry for the stuttering. I'm a little tired. So to me, it's really important to be very, very clear that managing people who happen to have personality disorders requires a lot of self-examination. And for people who are more sadistic, they might enjoy the fight with people with personality disorders, and that's not okay. It might make you more resilient in that discussion, in that therapy, but that doesn't mean you're actually helping the person. So it's not like there's one perfect way of dealing with these people who have these problems. And different people have different motivations for working the way they do with personality disorders. And being aware of that will relate to the game that you're stuck in. So if I were to summarize my approach, it's be clear about the game that you're playing. Be clear about what you think the other person's motives and intentions are. Check them, ask them, and see what you can do to help play the game more fair and more for the recovery goals the person's created with you. And if you happen to be a loved one of a person with a personality disorder, you're going to be stuck in games with them as well. And so being clear about what those games are, what moves are okay and not okay, and why is important. And doing so respectfully, with respect for the fact that their illness is something that's not always black and white, crystal clear, cut and dried, is also the challenge of personality disorders compared to other conditions. It's easy to identify compulsive behavior like washing your hands excessively. But understanding when idealizing and devaluing are not ordinary, like care and concern and liking people, isn't always super black and white, especially when personality pathology is on the table. So I hope it's very clear that people struggling with BPD need help, and they need special help. And the problem is, needing special help means that special kinds of people probably want to help them, which means they have their own issues. So countertransference management, crucial for people working with personality disorders. It's crucial for everyone working with every condition, but the capacity to harm people and be in a harmful dynamic is much higher, much riskier when it's about personality disorders. So I hope that makes sense to everyone. And I hope this has been helpful for everyone. I hope this all makes sense, and I always welcome feedback and criticism, because I think that the thing I'm trying to do here with this podcast is create a series of ideas and conversations that people who are consuming mental health services can look at and listen to and think about and go, okay, am I getting the most out of my therapist? Am I being honest with my therapist? Do I feel a pressure to perform for my therapist? And all that kind of stuff. And the same thing is true for psychiatry and psychology. I think it's always the case that there are dynamics in the room, and there are pressures institutionally, and I think there are pressures individually for us to perform for each other. And navigating that with mindfulness and non-judgment, I think, is important. And I think it's really hard to do because we are incentivized financially to look good, sound good, so on and so forth. And that can be the death of quality care and ethics. And so I hope this all makes sense, and I hope my motivations make sense as well. I'm not just here to trash talk the profession. I'm here to help create solutions and talk with people who are interested in solutions, you know? Seth says, solid chat, thank you. CareerFlex says, not all cluster B types even know that there are games. True. Or can address it. True. Or be honest about why they do that. Sure. So The various types of games are not super clear. Sometimes they can become clear through good therapy. Sometimes time is required to identify and understand the games. And I'm not saying games in a pathological, pejorative way. I mean in like a literal sense of like game theory. Like it's how we work. Because we're not supposed to be super 100% conscious all day. That would make us all crazy. So, all right, that is enough from me for this Saturday. I'm going to go enjoy the rest of my Saturday. I hope that all of you watching and listening enjoy the rest of your Saturday. Or if you hear this on a later day, enjoy your day. I very much appreciate everyone who showed up here in the chat. Seth and Jonathan and Jake and I think Angie and God, look who else was here. Corey, glad you're here, dude. Thanks for showing up. Phil is here as always. Yeah, like a super solid chat. Thank you all for being here. It really makes me feel good. It really genuinely makes me feel very good. And I want to continue these conversations. I want to grow these conversations. So thank you so much for the grist for the mill. And thank you so much for showing up in the chat. And we can talk about more things next week. If you want, Phil, I didn't ignore you. I said hello. So if you have ideas for next week's podcast or any podcast, shout out, please. Shout them out to me on Twitter. My handle on Twitter is at alobhapatrick, at ALOBHAPATRICK. So shout out on Twitter, comment on my YouTube channel on this podcast. Let me know. Come at me. I would love to know what we can talk about that's helpful for people who are actively seeking therapy or counseling or treatment. And Phil says, where's the joke? Phil, I don't have anything prepared. So I can try something off the cuff, but it could be terrible. So, it's totally up to you if you think I really should give it a try or not, No? No feedback? All right. Well, we will do a joke next week. How about that? Let's do a joke next week. I appreciate you all for being here. Please, again, share this podcast with everyone you know. I would love for more people to come into the chat to chat with me. Like, share, and subscribe. Follow me on Twitter, so on and so forth. See you next Saturday. Take very good care of yourselves. Eat good food. Have good sex. Have